Back here with us once again to talk about this, as well as testing, treatments, and more. Bill Gates, co-chair of the Bill and Melinda Gates Foundation. Bill, thanks so much for being back with us. It's been a little over a month since you were here, and at that time, you said the U.S. had not hit its peak. So at this point, do you think we have peaked, and where do you think we are right now in kind of the arc of the pandemic?
Well, we certainly hit our first peak, and if we stayed with the social isolation policies, then most places of the country you'd continue to see a decline. Because people are going to go back to more association in some places in the country, it's very likely that there'll be a future peaks as well.
And when you say future peaks, that's different peaks in different places, and that's more deaths. I mean, that's more deaths than would have been otherwise.
That's right. There will be deaths in the summer and in the fall. There's still some unknowns about the seasonality. Will we be lulled into complacency in the summer only to be pushed back up in the fall? And there's a lag time as people open up policies. You know, for the first month, not everybody will be taking advantage of those. So you can think, hey, these policies are good. Let's, go looser. And yet the people's behavior is just starting to take advantage of those. And so very quickly you can get yourself back into exponential growth.
Go ahead, Sandy.
That's a point that I think has really struck me this past week, Bill. I've been talking to a lot of people, and there does seem to be this cognitive dissonance. On one hand, people are acting like, we're close to the end of this and, really, taking victory laps in places. And then we hear, for example, Dr. Frieden wrote today that this is sort of still just very much the beginning, the worst health threat in 100 years, and reminding us that the Spanish flu took 2 years, really. I mean, I don't want to unnecessarily frighten people, but do you sense the same thing? Is there a cognitive dissonance right now?
Well, it's hard to deliver bad news, and particularly when we can't say it with 100% certainty. Maybe the summer is helping out here. But we saw Singapore, who was very tight. They opened up, they got a problem. They've had to close back down. Japan thought they could use certain policies, then had to declare an emergency. And Asia, it's important to say their testing and their contact tracing are of a quality far above the United States. The United States does not prioritize who gets tested, and the United States does not make sure you get answers within 24 hours. We haven't authorized kiosks or home testing. That's still a regulatory thing that's tied up. So our testing numbers should never be compared. If you're a high-income person, you can get tested a lot of times. If you're low-income, you're not likely to get tested at all. So our system fails to have the prioritization that would give us an accurate picture of what's going on.
Do you think there should be home testing that people can just do on their families?
Well, we have to make sure that we're applying the testing where it's necessary. But yes, you should be able to get a test at home if you're symptomatic. Then very quickly, all of your contacts, which would include your household, they should be tested. And that's, a perfect example where you need that answer very quickly so people know who should isolate instead of going out and being at work. And this becomes even more important as we're doing these opening up policies. So the speed of testing, South Korea happened to use kiosks. That worked well for them. In the US, we could use kiosks, we could use pharmacies, but we have to have prioritization and quick turnaround. Anytime you get an answer, say 3 days later, don't count that. Take that out of the numbers. These charts people show,
right.
You've got all those bogus tests and the inequity all built into that funny number.
Well, one thing, I don't know if you saw, Bill, Paul Romer's comments. He's a Nobel Prize winning economist. and this is going to sound far-fetched to people, but he suggests that the entire country essentially be tested every 2 weeks. And he says it is quite possible that if you go to places like the Broad Institute and a lot of university laboratories and the commercial laboratories that actually were able to do this, it costs about $100 billion a year, he said, but that would be the key to actually getting things open until we have a vaccine or something. When you hear those sorts of proposals, what do you think?
Yeah, I just wrote a piece in the foundation called Mega Testing. And the question was, can we get from this bogusly measured 200,000 a day up to what you just implied, which is over 20 million a day? That is a factor of 100 greater.
Yep.
And to an economist, okay, that must sound simple. But where was his system for collecting those swabs? Which swabs was he using? We haven't gotten the polyester swab approved by FDA yet, which would give you a lot of volume. BARDA's working with us on that, but it's got to get approved. But even to get the 200,000 to be real and to get it up to something like the 500,000, the lack of CDC engagement on the website with priorities means that that's really in bad shape. The contact tracing, you have to be able to quickly get a test out to that contact. That's what the Asian countries who've done well have shown us. So yes, there are approaches that may or may not work to get way above the 200,000 a day. They don't exist yet. There's things where you use agricultural PCR machines. There's things where you use CRISPR, and we should invest in those. But we can't count on getting to that, mind-blowing number, so-called mega testing. We should pursue it, but no strategy should be based on it because the chance of it working actually isn't super high.
So let me just double back to what you said. The 200,000 testing a day is, which we hear from a lot of podiums from a lot of people. You say that's a bogus number. Can you just explain why that's a bogus number?
If you get your test result within 24 hours so you can act on it, then let's count that. If you're making sure that low-income people have equal access, and it's not just, the delivery person who's asymptomatic getting tested every day, because they go into wealthy neighborhoods. The queues for that testing process, those are not prioritized. And so, if you have a relationship with a doctor who has a connection with the lab, you'll get to the front of the line. And other countries actually had criteria for taking this very scarce resource that's about saving lives, it's about seeing if we're doing the right thing, and allocating that in a just way.
Sorry, just pardon my ignorance on this, but so you're saying the tests that take 3 to 4 days to get results, toss those out because in that 3 to 4 days, that person is going to interact with an untold number of people?
Yeah, what's the point of the test? That's your period of greatest infectiousness. There's a little bit before you're symptomatic, which that's very difficult. But once you get symptomatic and you get that test, that's your key remaining days of infectiousness are about 3 or 4 days there. And so if you get the test 3 days later, and what's the point? Do you just write apology notes to the people you ran into for the last 3 days?
You should write apology notes. But I have a question about a op-ed that Michael Osterholm wrote about. I don't know if you saw it, Bill, but basically, we think of these tests as binary. If you can get one and you get the results, it tells you either you have the virus or you don't. But I was looking up some of these false negative rates, Bill, and I'm sure you've seen this as well. But even with these, if you get a good test, even some of these false negative rates are as high as 15%, some even a little bit higher than that. That's pretty significant. I mean, is that an issue that can be addressed, do you think? I imagine it would have to be brought down in order for all these other things that you're talking about to work.
Well, definitely as we look at non-PCR formats, that's going to be a huge problem. The PCR test, if it's done properly, that collected, which we've shown the self-swab does pretty well at that. If you get it to the machine in a reasonable time frame, it should be quite accurate. Now, we need to keep calibrating. It was great. Finally, somebody pointed out that the serology tests were particularly bad.
Right.
With them, lots and lots of false positives. So we need to keep calibrating these tests. Most of the PCR tests should catch a lot of the cases. And so I wouldn't expect to see a 15% false negative rate. But you also have that period where you're pre-symptomatic. And what we're seeing now is that your viral load, I was hoping the viral load would be low in the pre-symptomatic phase, and the studies that have been done as we go into homeless shelters, nursing facilities, what we're seeing is that there are a number of individuals with a very high viral load. And that probably determines your infectiousness, that are pre-symptomatic, and some who are never symptomatic, but that's far less than pre-symptomatic.